So not an ordinary fellow here again, and I got a page again. Uh, so let's see the page and what they want from me. So doctor, remember that patient that we saw last week? She has breast cancer, and the results of the biopsy shows ER/PR positive. Um, what will you do? MA. So this is my medical assistant. So let's go and study about that because, as you know, I'm a very young fellow and I need to dig into that before I talk to the patient. So the first thing is that I think we have to study adjuvant endocrine therapy for non-metastatic hormone receptor positive breast cancer. So that will be the topic of the talk. So what are the treatment options for patients with ER/PR positive disease? So hormone receptor positive breast cancer um, is present in 75% of the patients with breast cancer. Several meta-analyses have demonstrated that endocrine therapy improves survival outcome and has a favorable toxicity profile. And there is a wide consensus that any patient with a ER positive disease should receive adjuvant endocrine therapy. So we are talking about a very high level evidence, a meta-analysis showing that it is the right thing to do when you treat patients with a hormone positive breast cancer. So what type of treatments you think when we talk about hormone endocrine therapy? So the first one and obviously the most famous is the tamoxifen because it is the uh, older medication. So what tamoxifen does, it is a selective estrogen receptor modulator, CERM. So it modulates the estrogen receptor. We can also use aromatase inhibitors, which blocks the peripheral conversion of androgens to estrogens. Um, so it's a different type of mechanism. And we can also do ovarian suppression or ablation, which will inhibit endogenous estrogen production from the ovaries. And that can be done in two different ways. One is the temporary basis with ovarian suppression, or permanently through oophorectomy or radiation, also known as ovarian ablation. So, in a nutshell, we can use tamoxifen, AI, or ovarian suppression. And the ovarian suppression can be uh, temporary with pharmacological agents, or through ovarian ablation or oophorectomy, which will be permanent. So how is the treatment approach? For women with ER/PR positive breast cancer, adjuvant endocrine therapy is recommended regardless of the size of the tumor. So anyone with ER/PR positive breast cancer should be receiving adjuvant endocrine therapy. So the treatment decision is based on the menopausal status. So if the patient is premenopausal or postmenopausal. And menopause, um, it is important to understand that because that will affect the treatment decision. So we cannot only rely on amenorrhea as an indicator of menstrual status of the patient. And we do have NCCN menopause definitions that will help us guide the treatment. So NCCN has very good definition of menopause. So anyone that is 60 years old or older is postmenopausal. If you are below 60, then you have to have some criteria. One is to have bilateral ovarectomy. The other one is to not have any menstrual periods for 12 months or more in absence of tamoxifen, chemotherapy, ovarian suppression, and the serum estradiol is in the postmenopausal range. This is important to note that the patient cannot have had chemotherapy or tamoxifen and ovarian suppression because those things can interfere with the menstrual periods. Uh, Also, we can consider a patient in the menopause if they are amenorrheic on tamoxifen, if the FSH and the serum estradiol are in the postmenopausal range. And also for women who were premenopausal prior to the chemotherapy but experienced therapy-related amenorrhea, we need to have oophorectomy or serial measurement of FSH and estradiol to ensure postmenopausal status if we are considering to initiate aromatase inhibitors. We can use ultra-sensitive estradiol assays for monitoring reactivation of ovarian function. So this is a situation where the patient was having periods prior to the chemotherapy, and after the chemotherapy she developed therapy-induced amenorrhea. And that's not very uncommon because the chemotherapy is toxic to the ovarian function. And then in that case, we need to have oophorectomy or a serial measurement of the FSH and the estradiol so we can confirm the postmenopausal status, because we can only use aromatase inhibitors in that situation. Uh, So premenopausal woman. Um, so if how is the treatment for patients that are in the premenopausal? How is the adjuvant endocrine treatment in those patients? So if you have high risk features, so if high risk features are present, we need to use ovarian suppression plus aromatase inhibitor, um, and not use tamoxifen as single agent. The recommendations of ovarian suppression plus AI, they are based on the results of the suppression of ovarian function trial, also known as SOFT, in the tamoxifen and exemestane trial, the text. So no formal criteria to define a high risk. There's no formal criteria to define that type of patients, but usually patients that receive chemotherapy should receive ovarian suppression plus AI. And if they have the presence of pathologically involved lymph nodes, or if they have a large tumor size and it was a high-grade tumor, also if they have lymphovascular invasion, and a high risk of recurrence based on the genomic assay with a recurrence score over 31. And also, if you're younger than 35, probably you're at higher risk of recurrence. So, in a nutshell, if you are premenopausal and have high risk features, you should receive ovarian suppression plus AI. And although we don't have formal definition of a high risk disease, usually patients that got chemotherapy should receive OS plus AI. And also, if they have other pathological features like lymph node invasion, they have a large tumor, they have a high-grade tumor, lymphovascular invasion, or genomic psi scores with like a recurrence score over 31, and if they are younger. Yes, so again, in premenopausal woman, so in patients premenopausal that do not have the high risk features, so they did not receive chemotherapy, they don't have a high grade breast cancer, they don't have a lymphovascular invasion, the tumors are small, so then we should use tamoxifen as single agent. Historically, a course of 5 years of tamoxifen is recommended, but we can extend to 10 years in some patients. It is difficult to prove that more than 5 years of tamoxifen will improve overall survival because of the trials that studied that have many crossover among the cohorts, so it's difficult to show overall survival benefit. But despite of that, some patients will probably uh, be have a beneficial of if they take tamoxifen for 10 years instead of only 5. Uh, an aromatase inhibitor is not appropriate as single agent therapy for women with intact ovarian function. These include premenopausal women who became amenorrheic as a result of adjuvant chemotherapy because they may have return of the ovarian function during the follow-up. So patients with no high-risk features should get tamoxifen. We should not offer AI for those patients because they have ovarian function. Uh, Even if they were amenorrheic after the chemotherapy. So um, now we are gonna move on and talk about post-menopausal woman. So usually we have to use AI rather than tamoxifen. For women who wish to discontinue an AI, it would be reasonable to switch to tamoxifen. So if a patient for some reason doesn't want to get AI due to side effects, for example, they can switch to tamoxifen, knowing that in doing that they are not receiving the best treatment. All postmenopausal women who are candidates for endocrine therapy should be offered treatment, regardless of age. So even if you had a patient that is with a very bad or high performance status, we should still offer endocrine therapy because it has uh, a very good toxicity profile and would probably help any patients regardless of age. So ovarian suppression or ablation. So this is uh, um, the OS, the ovarian suppression that we can use in patients that are premenopausal with high risk features. So premenopausal woman, the ovarian function can be permanently suppressed by surgery or pelvic radiation. So if you do oophorectomy, bilateral oophorectomy, or radiation, you can have permanent suppression of the ovarian function. Temporary amenorrhea is also possible with pharmacologic interventions to induce ovarian suppression. So we can use GnRHa, gonadotropin releasing hormone agonists, in order to achieve that. So in patients with average risk and they are premenopausal, you can offer ovarian suppression (OS) with tamoxifen or AI. AI provides some beneficial over tamoxifen alone. So actually, no, AI and tamoxifen plus ovarian suppression provide some beneficial over tamoxifen. But if you do ovarian suppression, it can increase the toxicity, and it has to be individualized decision. So let's talk about the soft trial. So in this study, they studied three types of, they had three arms. One arm got tamoxifen, the other arm got tamoxifen plus OS, and the other arm got AI, which in this case was exemestane plus OS. It was a phase 3 clinical trial that studied patients in the premenopausal uh, um, state, and they were hormone receptor positive, and the use of chemotherapy was optional. So tamoxifen plus ovarian suppression improved 8-year disease-free survival rate, and also exemestane plus OS showed improvement on survival in comparison with tamoxifen alone. Tamoxifen plus OS also modestly improved survival rate compared with tamoxifen alone, so 93.3 versus 91.5. So very minimal overall survival benefit, but still there. However, freedom from distant recurrence at 8 years was similar between patients receiving tamoxifen plus OS versus tamoxifen alone, 89 to 88, and it was modestly improved for those patients receiving AI, exemestane plus OS, so 91% to 95. So based on the soft trial, we now recommend that patients that have high risk breast cancer, um, and they are in the premenopausal state, they should receive OS plus AI. Although the benefit of adding OS and AI in comparison to tamoxifen alone are not extremely high, it is significant. So, what are the toxicities of those additions to add OS and AI? So they have a higher amount of osteoporosis and musculoskeletal side effects. So 42% in patients with exemestane plus OS in comparison with 28% in tamoxifen plus OS and 14% in tamoxifen. So much more side effects in the OS plus AI. So taking together, this data suggests a possible modest disease-free survival benefit with the addition of ovarian suppression to either tamoxifen or AI. Uh, if you compare that over tamoxifen alone, um, and usually because you have so much more side effects, it does not justify to add those toxicities to the most average risk patients. So, high risk premenopausal patients. After the results of the SOFT and the TEXT trial, we should offer AI rather than tamoxifen when combining with OS uh, for patients that were high risk. And I said before, mainly those patients are the patients that received chemotherapy. Um, so if a patient got chemotherapy, they probably need, and they are premenopausal, they should receive OS plus AI in opposed to tamoxifen alone or tamoxifen plus OS, although the combination increases the side effects, including osteoporosis and musculoskeletal disease. So just to make it very clear, so usually approach when patients are receiving chemotherapy, they should receive, and they are ER/PR positive and they are premenopausal, they should receive ovarian suppression, for example, temporary ovarian suppression with GnRH agonists and AI. So ovarian ablation is a permanent strategy, uh, and you can do it through oophorectomy, bilateral oophorectomy, or with pelvic radiation therapy. Uh, it is associated with long-term health effects, including cardiovascular disease, and there is limited data available, uh, um, but it suggests that it may be more effective in women less than 40. Um, so that's a strategy of ovarian suppression. The temporary strategy is used in suppression with luteinizing hormone releasing hormone, so LHRH agonists, and you can use the goserelin, leuprolide, and triptorelin. The side effects of OS and endocrine therapy are usually seen as hot flashes, sweats, weight gain, and decreased libido. So, what is tamoxifen? So, tamoxifen is a SERM, so selective estrogen receptor modulator, and it inhibits the growth of breast cancer cells by competitive antagonism of the estrogen receptor. So it goes in the receptor and it competes with the estrogen from the body. The dose is 20 milligrams daily, and we have a meta-analysis showing that it is effective in patients with ER/PR positive disease. The side effects of tamoxifen is to increase the risk of thromboembolic disease. So you have the increased risk there. They also increase the risk of uterine cancer, and also fat liver disease. You can have hot flushes, sexual dysfunction, and there is increased risk for diabetes. So the most important here is like the increased risk of thromboembolic disease. Probably if you have a patient with a previous history of DVT, so we should talk about that and discuss the risk, and also a risk of uterine cancer. So, how the body develop resistance to tamoxifen? So there is a variable expression of the ER alpha and beta isoform. So that can cause the tamoxifen to be not so effective when they try to block the estrogen receptor. So we can also have alternative splicing of the estrogen receptor, and there is also modulators of the expression. And you also have people that they are inherit drug metabolizing the CYP2D6 genotype. So they will metabolize the drug faster. So aromatase inhibitors. So how does it work? It suppresses plasma estrogen levels by inhibiting or inactivating aromatase. So as a class, AI have consistently shown to improve outcomes for postmenopausal women compared with tamoxifen. So postmenopausal women should receive AI instead of tamoxifen. AI are inactive in women with intact ovarian function. So if they are premenopausal, the ovaries are still working, they should not get AI unless they are getting ovarian suppression therapy. So and also you have to keep in mind that therapy with chemotherapy can cause amenorrhea. So that's why we have to use the definitions from the NCCN for menopause. So the AI, so you can use anastrozole 1 milligram daily, letrozole 2.4 milligram daily, or exemestane 25 milligram daily. If you compare all the AIs, they have similar outcome and tolerability. So individual patients may tolerate one of the AI better than the other. So it's reasonable to switch to alternative AI if the initial AI was poorly tolerated. In other words, if the patient was getting letrozole and is having side effects, you can change it to anastrozole without any problems because they're very comparable in terms of outcomes. So the side effects from AI, musculoskeletal side effects are very important. So you can have carpal tunnel syndrome and also AI-associated musculoskeletal syndrome, joint pain and stiffness, and 20 to 70% of patients can have arthralgia. So very common to have pain as a side effect of AI. AI is associated with musculoskeletal syndrome, and this syndrome is responsible for discontinuation of AI treatment in 10 to 20% of the patients. So AI-associated musculoskeletal syndrome. So when you have a patient like that and they did not respond to NSAIDs, uh, so if they are willing to stay on AI, you can discontinue the drug for 2 to 8 weeks and then begin a different AI. So you have to stop the AI for 2 to 8 weeks and change to a different one. So you cannot just swap it like immediately. Um, you can also continue with the AI despite the musculoskeletal syndrome and the complaints, and you can give a limited course of duloxetine. So usually give 30 milligrams daily for 1 week, then you increase to 60 milligrams for 11 weeks, and then you reduce the dose to 30 milligrams daily for 1 week. You can also use acupuncture, and if the patient is not willing to use AI, you can change it to tamoxifen. So AI in this set of patients has shown to be more effective, but tamoxifen is also a good choice. So reactivation of the ovarian function. AI should not be used as monotherapy in perimenopausal women. So that's it. You cannot use AI in patients as a monotherapy in patients that are premenopausal. So in one study of 45 patients, 29 patients actually recovered ovary function after they lost ovarian function due to chemotherapy. So that's why we cannot use AI. I mean, you cannot pretty much assume that the patient that had the ovaries suppressed when they were in chemotherapy, that they will not recover their function, and that's one of the reasons you cannot use AI and as a monotherapy in those patients. So recovery of ovarian function with AI has a negative effect on the breast cancer. Okay. So what's the duration of the endocrine therapy? So minimum 5 years. And then some patients will be selected for extended therapy. So if you see a patient with a larger tumor, for example, higher than T3 in a node positive disease, they may be a good candidate for extended therapy. Observation data suggests that the risk of distant recurrence after 5 years continues steadily for at least the subsequent 15 years. So you were treated for whatever type of breast cancer you had, you got a certain type of treatment, and you are considered to be disease free. And then you got 5 years of endocrine therapy. So what should we do now? So there is some observation studies that shows that you can have the cancer coming back for at least 15 years after that. And even there are some reports saying that it's even more than 15 years. So that's why the duration of the endocrine therapy can be discussed with those patients, especially if they have a large tumor, which would be like T higher than 3, and they were node positive. Patients with many positive nodes were at an annual risk of distant recurrence of nearly 3% a year. So many nodal disease is definitely a high risk for patients, and they can have distant recurrences in 3% a year. So that's something to consider. Uh, what's the timing for the endocrine therapy? For women with hormone receptor positive that are not receiving radiotherapy or chemotherapy, endocrine therapy is usually initiated 4 to 6 weeks after the surgery. So surgery, and they're not getting radiation, they're not getting chemotherapy, start the endocrine therapy in 4 to 6 weeks. For patients receiving adjuvant chemotherapy, the initiation of the endocrine therapy is commonly begun after chemotherapy has completed. So you wait for the chemotherapy to finish and then start the hormone therapy. For patients receiving radiation, endocrine therapy can be used at the same time. Or, I mean, if you want to use after, you can also do it. So a patient that is ER/PR positive and they are also overexpressing the HER2. So adjuvant chemotherapy plus trastuzumab followed by maintenance trastuzumab usually is the treatment of choice, and and you complete trastuzumab for over 1 year. And when do you need to start the endocrine therapy? So most of the physicians would start endocrine therapy just after the chemotherapy, and continue with the trastuzumab, um, regardless the use of the trastuzumab. So special population, so obese women, patients with a high BMI don't need to adjust the dose, okay? Women of childbearing potential you should advise that tamoxifen can induce ovulation, and they have to use the effective means of contraception. So women who become pregnant and they are using tamoxifen, they should discontinue the treatment because it is associated with relative high frequency of congenital abnormalities. And endocrine therapy can increase the risk of the cardiac risk because the patients they have less estrogen available, and it is commonly known to increase the risk of heart disease. So um, and for patients with mucinous or tubular cribriform histologies, approach is the same as other histologies, but mucinous and tubular cribriform they have better prognosis. It's just to talk about kind of a different histology and how to approach that. So approach will be the same, but they usually have better prognosis if they have mucinous or tubular cribriform histologies. Okay, so thank you so much for your time. Please subscribe and wait for more informations on our channel. Thank you.